I'm Gina Ragland with the Nebraska Medical Association. I'd like to welcome you to the sixth and final in the 2012 Foster Healthy Weight in Youth webinar series, Breastfeeding, the Final Vital Step Towards Fostering Healthy Weight in Youth. Please note that today's webinar will be recorded. You are in a listen-only mode at this time. You can type questions at any time during the webinar in the questions chat section to the right of your screen. Questions will be yielded at the end of the presentation. Or if you prefer to ask your question in person, you can press the raise your hand button and we will unmute your line during the Q&A at the end of the presentation. If you have any problems seeing or hearing the presentation at any time, please let us know under the questions chat section. We'd first like to thank Dr. Carla Lester with Teach a Kid to Fish and the Nebraska Medical Association's Childhood Obesity Prevention Project, Holly Dingman with the Department of Health and Human Services Nutrition and Activity for Health Program, Dr. Christina Fernandez with the HEROES program at Children's Hospital and Medical Center, Dr. Sally O'Neill, Jeff Klein, and the staff at Creighton University CME, and Dr. Laura Wilwarding, UNMC, for the work they've done to make this webinar possible. I'd like to introduce Dr. Carla Lester, who will talk about the CME credits associated with this webinar, and will give the background of the Foster Healthy Weight in Youth model. Dr. Lester is a pediatrician here in Lincoln that started a nonprofit organization called Teach a Kid to Fish. Its mission is to prevent and reduce childhood obesity by empowering Lincoln children and families to eat healthy and be active. Dr. Lester also developed the NMA's Childhood Obesity Prevention Project. Dr. Lester?
Thank you, Gina. Welcome everybody to the webinar. We're pleased to be able to offer 1 hour of free CME and continuing education to those participants who qualify. The Creighton University School of Medicine designates this live activity for a maximum of 1 AMA Category 1 credit, and the information in the training has been approved by the American Medical Association, Creighton University Health Sciences Continuing Education, and the Commission on Dietetic Registration. And you will have received a detailed information sheet containing this information accompanying your webinar registration. This activity has been planned and implemented by Creighton University Health Sciences Continuing Education, the NMA, Teach a Kid to Fish, and the Nebraska Department of Health and Human Services. And neither the planning committee nor speakers for the webinar series have any conflicts of interest or disclosure and a signed statement claiming as such. After the webinar, you will be sent a link to the post-test and evaluation via email, but you may also visit cme.creighton.edu for more information. And I'm going to tell you, just take a few minutes to talk about Foster Healthy Weight in Youth, which is Nebraska's clinical childhood obesity model. The resources have been disseminated to physicians across Nebraska. Foster Healthy Weight in Youth is a comprehensive model with a toolkit, pocket reference algorithm, free CME training video, which outlines the steps in assessment, prevention, and treatment in the primary care setting. And then there are also consistent messaging, patient brochures, and posters to resource your office with. All of the resources are free and are available through the NMA's website. If you go to the Childhood Obesity Prevention Project page, you will find those. And I'm excited to tell you that today's webinar is titled Breastfeeding, the First Vital Step Toward Fostering Healthy Weight in Youth. Our speaker is Dr. Laura Wilwarding, a huge champion for kids' health in our state and for breastfeeding. She's from UNMC. Dr. Wilwarding is an international board-certified lactation consultant, a fellow of the American Academy of Pediatrics, a fellow of the Academy of Breastfeeding Medicine, and a clinical professor of pediatrics at the University of Nebraska Medical Center. Dr. Wilwarding?
Well, thank you so much, Carla and Gina, and it's a pleasure for me to be here today. I'm always a little technically challenged with these things, so hopefully I can make everything work. And I am going to apologize ahead of time. This talk is fairly science-heavy, data-heavy, but that's not the point of it. The point of it really is to point out the major issues in the data, just so people understand that this is evidence-based. Because breastfeeding is one of 3 major approaches that we've taken in the state plan for obesity prevention. And the 3 that we've included, of course, are healthy living, which is or active living, healthy eating, and then breastfeeding promotion. And those are all CDC proven areas that really do make a difference in obesity prevention. So that's why we're talking about breastfeeding today. And of course, everyone who knows me knows that that's what I usually talk about. So that's what you get when you ask me to talk. I want to start with talking about really just some very basics, and those of you on the call and those of you involved with this project obviously know some of these numbers, and the exact numbers aren't important other than to know that this is an epidemic. So in the U.S., approximately a third of children over the age of 2 are overweight or obese, and of those children enrolled in federal programs like WIC, the number rises to around 40%. And what we found is there's a lot of great programs that are aimed at school-age children and parents, and not that they're not worthwhile, but without a good incorporation of pregnant women and infants into these campaigns, we're not going to have as much of a far-reaching and long-term effect. And that's been shown in some of these interventions. And so I'm not discounting the need and the value of programs that certainly that are impacting older children. But the point of this talk is that breastfeeding promotion is really the first step that we can take to set the groundwork for all the other good work that's being done in the area. So one of the issues that we have, and I wanted to touch on this fairly briefly, but was assessing the problem. One of the issues is that in the United States for years we've been basically using growth curves that reflect how kids are growing and gaining weight, not how they should be growing. Okay, so these charts that were put out by the CDC and have been in the past actually even published through the formula companies, not surprisingly, incorporate all the short and tall, thin and fat, sick and well, and they all show how they do grow, not how they should grow. So the WHO, the World Health Organization, decided that we really should try to figure out what normal growth is in optimally fed babies, and this is up through the age of 2. So with breastfeeding as the gold standard for infant growth and development, it was necessary to design this study to develop guidelines for appropriate growth. On the CDC curves, oftentimes breastfed infants were seen as underweight or failing to thrive or falling off growth parameters instead of actually being having formula-fed infants being viewed as overweight. So what the WHO did, and this is, I actually was at a presentation in Chicago with one of the guys who was intimately involved with this, and this was an amazing feat to get this done. And it was over 1,800 infants throughout the world that were used in this study, and they didn't think they'd be able to get anywhere near that. But what they did is they did a longitudinal follow-up study from birth to 24 months, and then they also did a cross-sectional study beyond that, 18 to 71 months. And what was done is this was a group of children up through the age of 2 that were breastfed exclusively for 6 months and then had appropriate complementary feeding added at 6 months and older. This study was done with children from 6 countries, trying to reflect the different geographies and the perceptions that children in different parts of the world would grow differently even if fed the same. And these countries represented were the U.S., Brazil, Norway, India, Ghana, and Oman. The thing that was amazing about this is that the results from all 6 countries were superimposable. So this idea that children in Ghana will somehow grow differently than children in the U.S. when fed the same way was found to be completely untrue, and these results were absolutely superimposable. What we found was that well-fed, healthy children follow the same growth pattern around the world, and none in this group were considered obese or overweight. So this growth curve is very important for us to assess the issues. And if you notice, and I do this a lot in my practice because I have access to all the growth curves, and I will show the parents where their child is on both growth curves. And what's interesting is if you show a child on the WHO curve that's 50th percentile, they might actually be 25th percentile for weight on the CDC curve. And what that shows us is that our babies and these curves that have been used for years and years are reflective of the increasing weight of our infants because of the way that they've been fed. So a lot more work needs to be done, but epidemiologic evidence strongly suggests that breastfeeding represents an ideal window of opportunity for obesity prevention. We know that once a child becomes obese, it is quite likely that he or she will remain obese as an adult. And there are multiple theories that exist to explain why breastfeeding is the best start to prevent obesity. So what we're going to look at next is what the research shows us. And this is a little bit boring, so bear with me. And I'm not going to necessarily read every word on these slides, so these are more for your information. But what we need to know is that there have been a vast number of studies looking at this, and there are a number of questions that have been asked and answered, and there are a number of questions that we still need more evidence and information about. But what we're looking at today is really a group. We're going to spend most of our time considering 3 groups of meta-analysis. Okay, and these groups of meta-analysis were done by 3 separate groups: Ahrens, Owen, and Harder. So we're going to talk about those 3 meta-analysis. And what they were looking at is the relationship between breastfeeding and pediatric overweight. And these were using studies, predominantly used studies that were from developed countries. So just so everyone knows, not to insult your intelligence, but a meta-analysis is basically a statistical analysis of a collection of studies. So what it does is it takes a group of studies and says, yes, this one study showed this, but what do more studies show, so that we can understand what the value of those studies are. Obviously, if we have a study that we can find one study that'll show us something, and it could prove almost anything. But if you have 10 studies looking at the same thing and they all show you the same thing, it's much more likely to be valuable. And so that's why they do these meta-analysis, in hopes of identifying consistent patterns and looking at sources of disagreement among the results. So the first group that we're going to look at is Owen, and these were all done in the mid-2000s. There's work being done now, but there have not been, as far as I'm aware of, any good meta-analysis since then yet. I'm sure they're being worked on. But Owen's group excluded duplicate reports of results, but did not require an adjusted odds ratio. And all this really means is that they allowed any definition of overweight or obesity and included historical cohorts, prospective cohorts, cross-sectional, and case-controlled study designs. So they really had a pretty open model, and they actually looked at 28 studies and 29 estimates of effect. So it was a pretty broad-based meta-analysis, and these were all studies looked at from 1970 to 2004. Another group of meta-analysis was Ahrens, and he was a lot more restrictive in this group. They required population-based cohorts, cross-sectional or case-control studies, and they also included adjustment for at least 3 confounding variables. This is always a question because we say, well, in these kids who breastfed, they seem less obese, but are there other things in their history that make them less likely to be obese, or is it truly the breastfeeding? So Ahrens tried to address that by looking at more of these compounding variables. He also had more follow-up for 5 to 18 years, which is a big thing. And the mode of feeding was reported. They also, in this group, used BMI as definition of obesity. Some of the other groups didn't have a real good definition of obesity or overweight. And these studies were all published between 1997 and 2003. So these are a lot more timely studies. These are newer studies. And this is basically the diagram of Ahrens' meta-analysis. And I used this one because it's pretty telling and it has less studies to look at. But pretty much what you see with this line at 1, that's the odd ratio of 1. And what you can see in all of these studies, that the effect of breastfeeding versus formula feeding on childhood obesity with covariate adjusted odds ratios all were to the left of 1, meaning decreased risk of being overweight. And this is childhood overweight, okay? So basically this meta-analysis shows us, yes, in fact, it is true that breastfeeding does decrease the risk of overweight. Finally, in Harder's group, they excluded a lot more studies as well, and they also started looking at duration of breastfeeding and took out ones where they didn't compare breastfed to exclusively formula-fed infants. So again, there were more variables that were looked at in this group as well. The only thing with this group was that they didn't have as long a follow-up. So those are your basic 3 studies that when I'm asking these next questions, we're thinking about those meta-analysis, and that's how what we're using in terms of answering these questions. So the first question is what we already basically answered, is just generally, is breastfeeding of any kind, so meaning any amount of breastfeeding associated with a reduced risk of pediatric overweight? Both Ahrens and Owens reported that initiation of breastfeeding was associated with reduced risk of pediatric overweight. In Ahrens, they found all 9 studies showed reduced odds for overweight compared among children who were breastfed compared to those who were never breastfed. So again, this is any amount of breastfeeding. 3 of these showed non-significant effects in the same direction. But the meta-analysis of the 9 studies showed initiation of breastfeeding resulted in a significant overall reduced risk of overweight with an odds ratio of about 0.78, and it was statistically significant. So that's important. In Owen, looking at the 28 of 29 estimates, it also showed a lower unadjusted odds ratio of obesity among children who are breastfed than those who are formula-fed. Again, this is any amount of breastfeeding. The meta-analysis found lower odds of obesity among breastfed than in the formula-fed children. And the sub-analysis showed that when controlling for possible confounders, including socioeconomic status, parental BMI, maternal smoking, there was a significant inverse association between breastfeeding and the odds of overweight, but was reduced to about 0.86. So again, Owen showed the same thing, and this is any amount of breastfeeding. So then the next question is, and I get this a lot, does it matter how long you breastfeed? And if you breastfeed longer, does that seem to have increased protection? And what we find in these same studies, again, is that the duration of breastfeeding is inversely related to pediatric overweight. In harder studies, the greater the duration of breastfeeding, the lower the odds of overweight. And what they found was for each month of breastfeeding up to 9 months, the odds of overweight decreased by 4%. So this decline resulted in more than a 30% decrease in the odds of overweight for a child breastfed for 9 months when compared with a child who was never breastfed. So duration does seem to make a difference. The next question is, does exclusive breastfeeding have a stronger association with pediatric overweight than combined breastfeeding and formula feeding? And we get this a lot, why do we push this exclusive breastfeeding, and what's the big deal if we're giving some formula? Indeed, exclusive breastfeeding does appear to have a stronger protective effect than breastfeeding combined with formula. This is an area, though, that really needs to be looked at. And we're going to talk also about, are we talking exclusive direct breastfeeding? Are we talking about human milk in a bottle? There are more studies that need to be done. But basically, in harder, the 2 studies that documented exclusive breastfeeding also showed a stronger protective effect, decreasing the odds of overweight by 6% for each month of exclusive breastfeeding. And that's in addition to the protection for the duration of breastfeeding. So in fact, exclusive breastfeeding does have better protection than combined feeding, but more results or more research needs to be done because there are limited studies that have actually looked at this. So this is another really big question, especially when we're talking about breastfeeding being used for obesity prevention later. We want to know, does this association of breastfeeding with pediatric overweight diminish as the child gets older? And again, studies suggest that the protection against overweight from being initially breastfed rather than being given formula may persist into the teenage years and even into adulthood, which is very important. Among the 28 studies in Owen, the unadjusted odds ratio for obesity among those who were breastfed was 0.5 for infants, 0.9 for young children, 0.66 for older children, and 0.8 for adults. For adults, however, they were able to include only 2 studies. So there is an association with breastfeeding and overweight that appears to remain with increasing age of the child. But again, this is an area that needs to be continued to look at. And I have a lot of people that, say, well, of course, these breastfeeding, maybe that's the protection, but what other covariables and other risk factors are they getting over the years after they've been breastfed? So obviously there's lots of factors that are involved here, but it's an area that needs to be looked at. So I wanted to, that's basically the 3 meta-analysis, but I wanted to just throw in a newer study just to show you an example of a single study that was done. And again, this is a single study. It's from 2010. But I liked this study because it looked at siblings. Because that's the other thing I hear all the time. Well, my child's overweight because I'm overweight. Or we have, some endocrine problem. We're all overweight in my family. So does it make a difference in the same family if they're fed differently? So this set of analysis tests the association of breastfeeding with the development of overweight and obesity in childhood and adolescence, which included models controlling for fixed factors shared by siblings. So things like parental obesity, as well as some of the selection factors that may lead a mother to breastfeed one child but not another. So premature birth, recent employment status, or being a teen parent, that type of thing. So these were corrected for. So with these controls in place, what they found, and I do think this is fascinating because these are siblings, children who were breastfed were 4/10 of a standard deviation thinner on average than their counterparts who were not breastfed. So what does that mean? And I know when I throw out all these statistics and odd ratios, and it's like, well, what the heck is that all about, and why do we care, and does that really matter for me? But to put it in more concrete terms, in this particular study, the difference would amount to 13.5 pounds for a 14-year-old girl or 14 pounds for a 14-year-old boy. okay? And the logistic regression suggests that breastfeeding specifically reduces the risk of reaching the upper end of the BMI. So this is important, and it goes on into, for sure, teenage and even early adulthood. So I thought that study, and again, it was one study. I threw it in there because I thought it was an interesting perspective and a little different view of things than what we've looked at with the other studies. So ultimately, the data is there. We need a lot more data to really understand the true relationship between breastfeeding and obesity prevention. The other thing that we need is a better understanding of why this could be. So we find these results and we say, well, that's really interesting, and isn't that nice? But boy, wouldn't it be cool if we could figure out what's going on? And so there are a lot of proposed mechanisms, and that's what we're going to talk about today, because in actuality, we don't know any of these to absolutely be true, and we don't know if one is more important than another, but we think that there is interplay in all of these factors that affect how breastfeeding protects children from obesity. One of the issues, and what we're going to look at, is the physiologic and then behavioral mechanisms, okay? So in terms of physiologic mechanisms, breastfeeding is implicated in the initial organization of children's metabolic systems, okay? What that means is breastfeeding in infancy might protect children by setting them on positive trajectories with respect to appetite regulation. Not just appetite regulation, but actually the entire bacteriological flora of the gut that protects not only against illness, but also inflammation, and there's some thought that some of the obesity tracts can be an inflammatory process. But all of these things that are programmed in children from an early age with those first feedings of breast milk. One of the things in terms of physiology is we think that if children are better able to register the feeling of fullness, they'll be better able to establish healthy habits that we promote through our public health campaigns. So this is what we're looking at. What are these physiologic mechanisms and what are the behavioral mechanisms? And can we learn from this to even extrapolate that data and help even those babies who don't have the advantage and protection of being breastfed, but are there things that we can do with even babies who are not receiving breast milk that will help them and through some of these behavioral things? So physiologic programming. One of the things that we know is that there are obviously a lot of differences between breast milk and infant formula in terms of nutrients and hormones. Not only that, but if you've ever seen the poster of what, have you ever, did you ever wonder what's in breast milk or formula? Breast milk has biologically active components, and we don't even know what they all are. So there are all sorts of things going on and interplay in those that we don't even understand. But we do know that it is vastly different than what we find in infant formula. Some very basic differences is that infant formula has an overall higher protein content, and that's very important. Also, leptin is a hormone that tells us we are full, and it is only found in breast milk. There is no leptin in cow's milk formula. And the difference in early intake of these components could potentially lead to longer-term effects by programming the metabolic system and changing the set points of appetite or metabolism. From the very beginning, we could be screwing this up by not providing breast milk. So why is it important that formula has more protein? And why did formula companies put more protein? One of the things is when formula was designed, it was designed to emulate growth patterns, not so much outcomes. So even though if you look at a can of formula and you look at the nutrition content in breast milk, it's not exactly the same. But the reason they designed it that way is because of the growth patterns that they got. And now they've designed it such that we think that that growth pattern is actually normal. But the bottom line is that formula has more protein. And because of this, there is thought, and this has actually been documented, that it stimulates a higher secretion of insulin. And for those of you who don't understand, when we secrete insulin, that is what tells our body to store energy. When we store energy, we're storing it in fat cells. We're laying new fat cells. So because formula-fed infants have higher plasma insulin concentrations, they have a more prolonged insulin response. And this higher insulin concentration stimulates more deposition of fat tissue and actually new fat cells, which in turn increases weight gain, obesity, and the risk of type 2 diabetes. There's also thoughts that because cow's milk protein can look a little bit like the beta cells of the pancreas, there's actually some confusion in the body, and you can actually get sensitization of those cells and actually have insulin resistance over time. So particularly in families who have a history of diabetes, it's probably not a good a good idea to introduce cow's milk formulas early in life. Looking at leptin. Leptin is just being understood. It's pretty well understood now. What we know is that concentrations of leptin, which is the hormone that is thought to inhibit appetite and basically tell us that we're full and control body fatness, is influenced by breastfeeding. One study found that after controlling for confounding variables such as BMI, children who had the highest intake of breast milk early in life had more favorable leptin concentrations relative to their fat mass. And this goes on beyond infancy. So your ability to have biochemical control of your appetite is higher if you've been breastfed. There's also newer studies looking at ghrelin. A lot of people have heard of leptin. Fewer people have heard of ghrelin. Ghrelin is the hormone that tells you that you're hungry. And again, what we find is that there is downregulation of ghrelin, but a more sensitive use of ghrelin in babies who've been breastfed. So this whole biochemical ability to control your appetite and intake is very important. So we know that those are probably some physiologic mechanisms, and there may be others that we don't know. Those are the ones that have been generally implicated. But we also know that there are behavioral mechanisms. And in terms of behavioral mechanisms, it may be that breastfeeding promotes a feeding style that's more responsive to infant hunger and satiety, and that these children are set on a course to better regulate their own appetites. Anyone who knows or has breastfed a baby knows that you can put the baby to the breast, and oftentimes the baby will latch, but the baby will eat what the baby wants to eat at the time and will not eat if they don't want to eat, but they may stay at the breast. And sometimes moms don't realize that there's a difference in being at the breast and non-nutritively suckling versus being at the breast and actually transferring milk. But babies who directly breastfeed regulate their intake better, and they're better able to follow internal hunger and fullness cues. Bottle-fed infants, conversely, are encouraged by external cues to finish a feeding. And I have to say, I see this even in breast milk feeding with a bottle, and it's because anyone who's breastfed and has pumped milk knows that is liquid gold, and by God, you don't want to waste it. So if it's at the bottom of the bottle, we want them to finish the bottle. And we're going to talk about that in a minute and what the implications of that are. So bottle feeding versus direct breastfeeding, and this statistic just stands out, and this is with formula. This study wasn't done with breast milk in the bottle, but what they find is artificially fed infants, meaning formula-fed infants, consume 30,000 more calories on average than breastfed infants by 8 months of age. Okay, that should tell us enough. Babies who are formula-fed are just eating too much. Even if formula was equal, babies who are formula-fed are just eating too much. That is an equivalent of 120 Mars bars, or about 4 Mars bars a week. So give them a Mars bar every couple days and you'll be good. So bottle feeding, even with breast milk, can lead to overeating. And this is the kind of stuff that I'm talking about. These behaviors can be adjusted even in babies who are formula-fed. Okay? We really need to be better about helping parents realize that we need to be following hunger cues. We need to be following satiety cues. If the baby's turning their head, if they seem done, there is not a reason that we need to have babies finish their bottle. The other thing is encouraging taste feeding. Anyone who's been to a buffet knows, what do? Oh, we're hungry. We go to the buffet. Oh, it looks delicious. We get a great big plate of food, and all of a sudden we've eaten this huge plate of food, and now we feel sick, right? Same thing with a bottle. Those kids don't stand a chance. The stuff's pouring in their mouth, and even if it's breast milk in the bottle, it's pouring in their mouth, and they're eating it so fast, they eat it, and by the time they realize they're full, they've already eaten another half a bottle. Okay, so another thing that people can do is slow the feedings down, get the slower flow nipples, that kind of thing. But it's important that we train people, no matter what they're feeding in the bottle, to kind of follow those cues. I just liked this picture, and it doesn't actually, what it says on here is all about heart disease. It just says not to supersize him because we want to prevent obesity. It's not specifically about breastfeeding, but I used it as just a nice poster to just show that artificially fed infants eat more. So breastfeeding and obesity policy recommendations. The Centers for Disease Control consider there are really 2 potential cost-effective interventions that can be put into place immediately. And of course, breastfeeding promotion is one, ta-da, and decreased television viewing. Now obviously there's lots of other things, but these were very cost-effective and short-term use and when they originally came out with some of the recommendations. I'm going to go through these conclusions, but these aren't truly conclusions. We're going to go a little bit further beyond this slide. So what we want to know is that breastfeeding is associated with a reduced odds of pediatric overweight. It appears to have an inverse dose-response association with overweight, meaning longer duration, less chance of overweight. We need more research, but exclusive breastfeeding appears to have a stronger effect than combined breast and formula feeding. And also there's an inverse association between breastfeeding and overweight that remains with increasing age of the child. So overall, the 3 meta-analysis reviewed suggest a 15 to 30% reduction in odds of overweight from breastfeeding. So it's pretty clear. Again, more research needs to be done, but definitely this is the best approach to start and give them a good level playing field. Because we know decreased risk of obesity is conferred as the child ages into adulthood. We know about the physiologic and behavioral mechanisms, but again, more research needs to be done. And a big thing is that these behavioral mechanisms can be modified with appropriate education. Breastfeeding promotion and effective support are vital to ensuring a healthier next generation. So I wanted to take a little bit of time to talk about where we are now in Nebraska and what can we do. Because we know now this is an important issue, and what can we do to ensure the future health of our kids as they grow. So this is the 2011 numbers, and this is from CDC. And what we know right now, our U.S. national level of ever being breastfed is about 77%. Goals for 2020 are 82%. And Nebraska is doing a remarkable job in initiation because we are at 82.2%. This is from 2011. What you'll find, though, is the next number, which is breastfeeding at 6 months. And this is not exclusive breastfeeding. This is any breastfeeding at 6 months. This number drops from 82% down to 53% in Nebraska. It drops from 77% down to 47% nationally. So we're still a little better than the national average, but well below what we'd like to be at with the 2020 goals of 61%. This is very important because we know that the majority of women interviewed report that they did not meet their own breastfeeding goals. So there are a lot of things happening for these women, and it's not a matter of deciding to breastfeed or not deciding to breastfeed. It's helping women get through those roadblocks that are having them stop breastfeeding before they're ready to stop breastfeeding. Because every woman has their own goals, and they should never not meet their own goals if there's anything we can do about that. So looking at breastfeeding at 12 months, again, in Nebraska, we're a little better than the national average. This is any breastfeeding. And of course, we wouldn't want exclusive breastfeeding at 12 months because we want complementary feedings at 6 months. But a little above the national average, but still below the 2020 goals. But these next numbers are the ones, especially when we're talking about these protections against obesity and protections against chronic diseases. The duration and exclusivity are very important, and these are the numbers that we need to work on. Exclusive breastfeeding in Nebraska at 3 months is about 45%, which again is well below or well above the national average of 36%, and just a little below 2020 goals. But that's 3 months. Okay, that is minimal. But when you go down to exclusive breastfeeding at 6 months, that number is again cut in more than half, down to 20%, below the goal, although still above the national average. So what I will say, in Nebraska, we are doing a pretty good job, but we have a lot of work to do to improve these numbers. So what can we do in Nebraska and throughout the country? We know there are 6 evidence-based interventions to promote and support breastfeeding, and these are through the CDC. And what we know are breastfeeding-friendly maternity care practices, such as those in the Baby-Friendly Hospital Initiative, which unfortunately we no longer have any baby-friendly hospitals in Nebraska. This was a very sad commentary. I know Holly and I know we went to the meeting one year, and we were #1 in terms of the percentage of babies born at baby-friendly facilities. And now we are going to be last because I think we might be the only state that doesn't have any, although that might not be true, I'm not sure. But it's really depressing because for once Nebraska was leading edge, and now we're right back at the end again. The other thing we know that's evidence-based is support for breastfeeding in the workplace through the Office of Women's Health and the Breastfeeding Coalition. We have developed a great program for workplace education for employers so they understand what the needs of breastfeeding families are and can help implement them in the workplace. So that's something we're doing, and it has been evidence-based to help keep people breastfeeding. We also know peer support is very important. That's why programs like the WIC peer counselors do work, and we need to work really hard to protect funding for those programs because they're very, very important. Also, educating mothers. If mothers don't know what to expect from breastfeeding, then they're much more likely to supplement with formula. If they don't know that they're not going to have a large volume of milk in the first day or two of breastfeeding, then they're going to be much more likely to think they don't have enough milk. So education of mothers is very, very important. Another evidence-based intervention is professional support. And what that is, things like this, education for professionals to understand what the issues are and how they can best support and promote breastfeeding. Not just tell people it's a good idea, but put into practice things that really will work to help moms. And then, believe it or not, media and social marketing have been evidence-based interventions to promote and support breastfeeding. In our state, or in our city, I'm proud to say that Live Well Omaha has now done some billboards for breastfeeding. Grand Island, Jane Miller in Grand Island has done a great job doing that for years out there. It seems like a little thing, but I will tell you, after 50, 60, 70 years of an overabundance of formula marketing, we need to take back our share of the marketing and anything that we can do to get breastfeeding out there as normal in the media. And that includes getting coverage for breastfeeding issues, getting coverage of breastfeeding moms, not even for any special event, but just to see them in the communities, are very, very important. One of the things that we're doing through Partners in Health is a photo project that is supposed to show pictures of just good, healthy behaviors, including breastfeeding, and then barriers to good, healthy habits in Nebraska. So those sorts of things do work, and over time we need to develop more and more of them. So basically, this program of the Nebraska Medical Association and with Teach a Kid to Fish has been a wonderful program for our state. We need to get practitioners to utilize the resources and be educated in this, because this is something that we are going to have issues with for years, and unless we have a concerted effort to deal with this together, this obesity epidemic is going to continue. So I just put up these as good resources. I put our coalition site, anyone who's interested in the Nebraska Breastfeeding Coalition, we've got some great resources. Also, Partners in Health is awesome, because Partners in Health has good ways for people to design their own programs, not only for breastfeeding promotion and support, but also for healthy eating and active living. And it gives ideas of things that are within the state plan that have been shown to be effective in terms of promoting these behaviors. And then finally, my last picture, I just like pictures, but this is a great picture, and it says that breast milk is a perfect food that cannot be duplicated. It actually alters in composition to meet the changing needs of the growing infant. It does more than we know it does. And as we continue to discover these amazing things, we learn more and more and realize why it is so vital and such an important part of our big fight to prevent childhood obesity. So with that, I will close, and I'm happy to offer or to entertain any questions. I realize that there was a lot of information, a lot of data that's very boring, but mostly I just wanted you to get a sense that, in fact, this is not just fluffy stuff, that in fact there has been research done, and we do know that breastfeeding promotion is a very important first vital step for obesity prevention. Thanks.
Thank you, Dr. Welwerding. We will now open the webinar up to any questions you might have. Again, you can type your question in under the chat or questions portion at the right of your screen, or you can press the raise your hand button and we will unmute your line. And Dr. Welwerding, I don't show any questions, but I do have a comment from a participant. I just want to let you know. They said there's also good evidence that sugar-sweetened beverage policies and coordinated school health are cost-effective interventions.
Yes, and the reason, and I think that's a very good point, and thank you for pointing that out. That quote that I showed you is a very early thing, so that wasn't discounting some of those other things, and that is a really good point. And obviously, that was a quote that particular one was initial, and it had breastfeeding in it, which is why I glommed onto it. But yes, there are other evidence-based evidence-based strategies that include school health as well as the sugar-sweetened beverage, and that, of course, is a totally different topic, but a very good point. I've bored everyone to tears. They're all sleeping.
Just checking, Dr. Wilwarding, it does not look like right now we have any questions, but I think Dr. Lester has a question for you.
Sure.
Well, great presentation, Dr. Wilwarding. We appreciate it very much. I was just thinking, and this is just kind of an aside, but a recommendation that as much as we can, or what I've seen with breastfeeding over the last probably 5 years of doing Teach a Kid to Fish, is that as we have this kind of tangential momentum with obesity prevention and all those efforts that are tied into, what schools are doing and child cares and healthcare providers are doing, then you see, okay, here's the what the CDC recommendations are on the 6 strategies for communities for obesity prevention, listing breastfeeding as first, and saying that I've noticed, there really is also a great momentum, I feel anyway, and I hope you feel this too, towards increased breastfeeding. And there's just, I don't know, I think it's become more acceptable. And I just want to make sure that we are also working with physicians, with OBs, with pediatricians, and during the prenatal classes that we get this information to them so that they know that they can talk to moms. It also helps to prevent obesity in your children, because when you ask parents about whether their concerns on top health concerns, it's their child's lack of exercise and obesity. So it is a big issue, and if you can catch them early, and if more obese pediatricians, prenatal classes, they're really also talking about this.
Yes, and I think that's a really good point, and one of the strategies that we know that not only mother education, but education and professional support for those providers, it's something that individually I'm trying to do. I do, just next week, I'm doing a lecture on common breastfeeding challenges for the OB. Obviously, the prenatal, I think, actually, if you look at the numbers and you look at initiation and that sort of thing, somehow moms are getting the prenatal message, and I'm not sure who's doing a really good job with that, and I hope it's the OBs, and I think that there's at least general consensus that it's a good idea, but it's those issues afterwards, and I think right now the problem is there are so few physicians who truly feel comfortable or feel like they have good answers to support moms, even with basic things like medications and breastfeeding. So I still see all the time where women are told to stop breastfeeding because they're on this medicine or that medicine when it's completely not necessary. And so that education and support piece for professionals is really, really important. And I think as time goes on, that's going to be, we're going to have to spend more and more time and energy on that sort of thing. The other thing that I would say in terms of this momentum, it is actually very, very true. The momentum is finally things are kind of swinging in our direction. We've had some good help with healthcare reform in terms of protecting the rights of mothers and when they go back to work. So we have some things put in there. But I think we also need to continue looking at those supports throughout the community and find out what other things that we can do that will continue to help moms get past this barrier. Because moms know that breastfeeding is good, but when things aren't going well, most physicians don't feel well equipped to deal with that, and so we're going to really need to assess that. One other thing I would mention is that medicine now and hospital policies are oftentimes driven by cost effectiveness. And what they find in terms of health care outcomes and cost is that the higher their levels of exclusivity in the hospital, the lower their risk of complications, et cetera. And the Joint Commission has zeroed in on this. And, one of the core measures that Joint Commission has is a perinatal core measure that specifically looks at exclusivity in the hospital, which is a direct reflection of maternity care practices. Right now it's an optional core measure, but this is being looked at as potentially being a required measure for any birth center. And so not only is it the right thing to do, but it is cost-effective, and health outcomes are so obvious that those accrediting organizations are looking at that. So to support those kind of policies that are being put in place, above us, we really need to make sure that people understand the ramifications of the decisions they're making in terms of how they're supporting breastfeeding.
Okay, Dr. Woolworthing, we have a few questions in queue. The first one is, has any research been done on soy formula and if it has the same effects as cow's milk formula? Is soy formula as high in protein as cow's milk formula?
Right. Soy formula, there actually has been some research, not specifically compared to breastfeeding that I'm aware of, and I'm not going to be able to answer your question very well because, to be honest, I don't know the answer. However, what I can tell you in terms of the amount of protein and that sort of thing, soy protein is not the same kind of complex protein. Over the years, there have been issues with, it doesn't have lactose either, and even though, so many people think that lactose intolerance and these sorts of things happen in babies. In fact, unless you truly have galactosemia, being lactose intolerant is not compatible with life, and so in fact is not true. So there have been studies over the years, and these are old studies, where there was some association perhaps with increased risk of diabetes. We know that's true with cow's milk protein formula too, so I don't know if that's unique to soy formula. There are countries in which soy formula is not even on the market, because there have been other issues with soy formula. So my take on it, I don't have great evidence to tell you in front of me. Again, it's not a great question for me because I just don't know. But what I will tell you is there's very rarely times where truly soy formula is necessary unless there is a true cow's milk allergy. In that case, you would hope if they were breastfed, they wouldn't have either of those issues. So, so the answer is I don't really know, but that's kind of my take on it, if that helps.
Okay. There's an attendee that wants to know about using the pictures in your presentation, Dr. Woolworthing, if that's acceptable to do that, in particular the last one, and then there's a question about releasing the PowerPoint to attendees in a PDF format. Would you have a problem with that?
No, I think that's fine. I mean, realize obviously all of the studies are published, and I have all the bibliography and all that if it's ever needed, but that's where the studies came directly from, journal articles, so that's all from that. And the last picture, that is something, it's just on the web. So I'm not, to be honest, when I do these things, I kind of haphazardly use things from the web because they're on the web. And I'm like, if you didn't want me to use them, you wouldn't let them be on there. But I know there are some weird rules about that, so I guess I would defer to anyone else who knows the rules about that. But as far as I'm concerned, I certainly don't care.
Okay. The next question, or in follow-up, I guess, we'll go ahead and send that out to all attendees that we have on record. We'll email that out to everyone
sure.
so they have access to that. The next question is, does WIC deter single mothers from breastfeeding?
What was the question?
Does WIC deter single mothers from breastfeeding?
Does WIC deter single mothers from breastfeeding?
Yes.
Okay. Actually, that's a great question, and I think if you had talked to me years ago, and I've been in practice now about 15 years, I've been doing a lot of active breastfeeding stuff for about 12. And 12 years ago, WIC and I were not friends. And I even got up at one conference, and I think it about came to blows between myself and some people who worked for WIC, because my philosophy at that time was that WIC was just a formula depository, and in fact, people just went there to get formula, and they, that was pretty much their whole job, and they promoted that. What I will tell you is that WIC, in our state particularly, and I know other states WIC, but I can speak to our state's WIC, has done really a lot of great things to promote breastfeeding. One of the things, if you're not aware, WIC provides better food packages both for moms and babies. If they are breastfed, the more they're breastfed, basically the more good foods they're getting. They got rid of juice, which is great. There's a lot of things that WIC has done. They do have the WIC peer counselor programs, and I would say when you're talking about single mothers, obviously single mothers have all sorts of challenges, breastfeeding not being the only one, but single mothers are going to be a group in particular that very much benefit from the peer counseling program, and having someone who is a peer of theirs who's been through that. So I think, in fact, WIC is doing a pretty good job. Now, having said that, there are always going to be individual workers among WIC, among other organizations as well, that may go back to, let's face it, it's easier, it doesn't take as much time for us to give you your formula, okay? And I'm not saying that all WIC providers do that at all, but if you look at human nature, if you are very busy and you have a lot of other things to do, providing breastfeeding support takes a lot of time. And so I think WIC is trying to address those issues and are doing a lot better job of providing breastfeeding supports for not only single mothers but all WIC participants. And I think the infrastructure is there, but it's just still a little dependent on the individual WIC clinics. You know, like I know in Grand Island where Jane Miller is, I bring her up all the time because I think she's wonderful, but I know she's done a lot of great things there through their WIC program, and I know there's great things going on in Omaha. I don't know as much about Lincoln, but there really are good programs through WIC if they're being utilized. So that's what I would say. I do think the infrastructure is there, but it's still a cultural shift that is occurring, especially through workers who have been there for a long time.
Okay. We have a comment and more than a question. We also need to involve midwives and family physicians who deliver quite a few of Nebraska babies as well in the process.
Yes, I think definitely midwives, although, and, you know, family physicians definitely, and that's one thing I'm actually, I'm opening up a new practice in case anyone was wondering, but in my new practice, we're actually going to specifically train family physicians in our clinic, and so the model is certainly not one just for pediatricians, family physicians, obstetricians, pediatricians, mid-levels, and particularly midwives, although I would say I'm a big fan of the midwife model. I think that birth is generally a natural occurrence and should not be medicalized, if you will, like we've done. And I think with that model, generally, and not in every situation, but generally the breastfeeding support is pretty good with less intervention and that kind of stuff. Obviously, we still need professional support for midwives, but what I've found is that people who go who find themselves in midwifery are generally looking more holistically, and I mean, maybe that's not fair to other practitioners, but I guess I have a pretty high regard for midwives, and yes, we should involve them, but I think they're definitely on the front lines and doing a good job of helping moms establish breastfeeding.
The next question, what makes a facility baby-friendly?
Oh, well, that's a completely different lecture. And baby-friendly is an international designation. And they are the 10 steps to baby-friendly, and they can be found on the web. Just Google baby-friendly hospital initiative, and you can see exactly what those 10 steps are. When you have reached the 10 steps, there's an accreditation process, and then there's also a process by which you're reviewed. I can't remember if it's every 5 or 10 years, but it's all very specific on the website. The catch to it, and a lot of reasons that hospitals choose not to do it, is that you cannot accept any sort of free formula, and hospital administrators oftentimes feel like they're getting a really good deal by getting free formula. So that's often the catch. Many times hospitals actually do follow most of the steps, but just can't quite make that one, or they don't want to have other, kind of supplements taken away from them. They feel like they're losing some control. There is some money that it costs as well, although it's not a huge amount. It's generally founded because it's an international designation, and there's been good research showing that, in fact, rates from baby-friendly hospitals, it does make a difference in terms of duration of breastfeeding, and that's been studied pretty extensively. So if you're interested in that, I would recommend just going on the web and looking at the Baby-Friendly Hospital Initiative. It's BFHI, and it's an international designation.
The next question, any simple patient education materials that are available? How do they access those, or where would you recommend?
Wow, that's a loaded question too, and there are so many things out there. The only thing, and there are things that I use, but it's hard. I mean, the main thing is that you want to be sure whatever, and there's lots of patient education out there, but whatever patient education that you're using, it's evidence-based, it's based on something, not just somebody's whim. So, for me to tell you one specifically is a little bit hard, but just make sure that, as you're looking through patient education, I mean, there's definitely good information through the CDC. There's definitely good information through the U.S. Breastfeeding Committee. There's definitely good information through the Academy of Breastfeeding Medicine. They have all sorts of protocols and that sort of things. But in terms of patient education, there's just so much stuff out there. Just always, be sure that it's something that's relatively evidence-based and practical. But those resources, the U.S. Breastfeeding Committee, the ABM, and the CDC should have some pretty good starts for you.
Okay, I show no further questions in queue, Dr. Welwerding, so we will wrap things up. Just a reminder for everyone to please go online and access the link code that will be emailed to you within the next hour or so following the webinar, where you can receive 1 hour of contact medical education credit hours through Creighton University. Also remind everyone of the Childhood Obesity Prevention Project. You can join the COPP by visiting the link on the PowerPoint, or you can just go to the NebMed website and access it through that link as well. And lastly, please use and promote the model, the Fostering Healthy Weight in Youth, that toolkit, as well as any of the downloadable materials. If you do want those in hard copy form, you can email Holly Dingman at the state, and her email is shown on the screen above, or you can access that through the website that's also listed. In closing, thank you for attending, and have a great day.
Thanks, Gina.